Greetings, my name is Juliana Boyle and I'm your host today for our webinar, Health Reform, EMS, ED, and Trauma Center Impact, Where Do We Go From Here? This 90-minute webinar is presented by the Abaris Group, a consulting firm that specializes in ambulatory care, emergency department, trauma and EMS planning, program implementation, and financial analytics. We have an excellent presentation for you today and are glad you've joined us. We have two nationally recognized speakers presenting today. Good morning, Dr. Regenstein.
Good morning.
Good morning, Mike.
Good morning.
We are looking forward to your presentation, but first let me quickly go over some housekeeping issues. You should be seeing our welcome slide on your screen. If not, please call our webinar provider, GoToWebinar, at 800-263-6317 and follow the prompts for technical support while in session. With respect to questions, please feel free to submit them anytime. To submit a question, type it in the designated questions area in the control panel and click Send to submit. We will answer questions over the audio system and not on the computer screen. Also, it would be helpful to include your city and state. Those questions that are not answered during the webinar will be answered via email, and a copy of the Q&A will be sent to everyone. You should have received an email packet of information about the webinar. Please have all participants complete an evaluation and list their contact information on the webinar participant list. Please email these forms back to us immediately following the webinar. If you did not receive these documents, contact the Abaris Group after the presentation. Finally, this webinar is being recorded. We hope to have it on our website free of charge, and I'll notify you when it's available. And remember, if you have any technical support questions, call GoToWebinar at 800-263-6317 and follow the prompts for technical support while in session. Now let me tell you a little bit about our speakers today. Dr. Regenstein is a professor in the Department of Health Policy at the George Washington University School of Public Health and Health Services and also directs the Doctor of Public Health program. Dr. Regenstein has substantial experience investigating issues of importance to the healthcare safety net. She has led assessments of healthcare access for low-income and underserved residents in approximately 24 communities across the United States. She is also the principal investigator for the George Washington University AHRQ Action 2 Network. Our other guest speaker today is Mike Williams. Mike is president of the Abaris Group and has over 30 years in the operation and design of emergency care systems. He is a specialist on health reform with respect to pre-hospital, outpatient and inpatient services, and on regional delivery systems at the safety net and traditional payer levels. He recently completed an assessment on health reform for the Sacramento, California region, assessing its impact on primary and emergency care services. Let's begin with the presentation. Dr. Regenstein, I'd like to turn the floor over to you.
Thanks so much. Today we're going to talk about the Patient Protection and Affordable Care Act, which I'll refer to as the ACA. I'll present an overview of the law, but I'm by no means covering all of its many provisions. This is truly a comprehensive piece of legislation that will affect nearly all aspects of the healthcare system. And just in the way of background, the ACA is not the first time in our nation's history that comprehensive health reform has been attempted. Just a few examples: President Franklin Roosevelt seriously considered including health insurance in his social program initiatives. President Richard Nixon proposed legislation to Congress that would have required all employers to provide health insurance. And of course, we all remember President Bill Clinton's attempt to create a health system with universal coverage and insurance reform. The goal of comprehensive health reform is not new, and neither are the reasons why it's necessary. Costs are skyrocketing, too many people are uninsured or underinsured, and increasingly we're learning that the U.S. is being outperformed by other countries on common measures of healthcare quality. Slide, please. When we talk about the position and dominance of the U.S., Julia, thank you, we can truly say we're #1 when it comes to health spending. This chart compares per capita health spending in the U.S. to per capita health spending in a few other countries with similar economic positions. In 1970, the U.S. was spending roughly the same amount of money on each of its residents as other similar countries. But somewhere in the late 80s, U.S. per capita spending really took off, and started to diverge from patterns in other countries, with the gap between the U.S. and the next highest country getting wider and wider. Next slide, please. One of the more perplexing questions about healthcare spending is, where's all that money going? How's it being spent? And are there ways to slow the growth of healthcare costs without compromising quality? If you look at the map on your screen, you'll see a bunch of regional divisions. These were created by the Dartmouth Atlas Project, which examines regional variation in healthcare utilization and quality of care. That project divided up the country into about 300 regional healthcare markets for tertiary care. The darker regions indicate higher amounts of health care, and the lighter regions indicate lower health care utilization. This map illustrates the high variation across the U.S. in terms of the use of health services. And the data refers to Medicare patients only. So all of the utilization is for essentially the same group of patients. All of them are insured by the same public program with the same benefits, regardless of where they live in the country. So one might guess perhaps regions with higher use are doing something better for their patients and seeing better outcomes. Next slide, please. But if you look at the next map, you'll note that the substantial variation in quality, in this case related to one aspect of diabetes care, bears very little resemblance to the substantial variation in spending. What the Dartmouth researchers have found in more than 2 decades of work is that there does not appear to be an association between more care and better care. Next slide, please. The data we just saw reflected an insured population. But in fact, just as many people are uninsured as are covered by the whole of the Medicare program. For the past 25 years, we've had a remarkably steady uninsured rate, in part because we have a public insurance entitlement program, which is the Medicaid program, that's available to some people when economic conditions push them into poverty or near poverty. Currently, there are about 50 million uninsured residents. Next slide, please. On March 23, 2010, President Obama signed into law the Patient Protection and Affordable Care Act. The implementation of the ACA takes place over a decade, with certain provisions coming online with the passage of the law and others playing out over a 10-year period. First, the ACA expands health insurance to millions of people who previously were unable to obtain health insurance. The original estimates by the Congressional Budget Office and other groups were that about 32 million people would become newly insured as a result of the ACA, about half through new private insurance markets and about half through expansions to public insurance programs. We'll talk a little bit about how the Supreme Court ruling is affecting these estimates, but it's safe to say that if the ACA stands after the November elections, around 30 million of the uninsured will get an insurance card, and with it a guarantee of coverage. Second, the ACA reforms the insurance market, making it illegal for insurance companies to deny coverage or raise premiums based on pre-existing conditions. Third, the ACA sends a strong message that poor quality care will not be paid for by the Medicare program, and that building a higher performing health system requires partnerships within and across highly integrated health systems that are incentivized to produce results. Fourth, the ACA requires minimum levels of benefits across health plans and includes requirements to offer preventive services with no out-of-pocket cost to the patient. And fifth, the ACA expands primary care capacity in anticipation of substantial increased demand from newly insured individuals. Next slide, please. So let's just take a step back and talk about the way our current health insurance system works today. Most of us get our health insurance through our employers. Almost 2/3 of employers offer health insurance to their employees. Large employers are more likely to offer health insurance compared to small employers, but overall, about 63% of employers offer health insurance as a benefit. Employers generally pay part of the employee's premiums. Many employers pay about 80% of the premium, and the employee pays about 20%, but some employers pay a far lower percent of the premium, or they vary their contribution based on the type of plan selected by the employee if in fact they offer a choice of plan. Some employers also offer coverage to employees' families, and again, the percent of the premium can vary quite a bit. Even in places that offer health insurance, some employees may be ineligible for coverage. Employees that work less than full-time, for example, are often not eligible for health benefits. Most of the time, about 82% of the time, employees who are eligible for health insurance do take the offer and will enroll in the health plan. All told, about 3/5 or 60% of workers get some level of health insurance from their employer. Currently, only 2 states require employers to provide health insurance to their employees. One is Massachusetts, which implemented comprehensive health reform in 2006, so-called Romney Care, and the other is Hawaii, which for more than 3 decades has required certain employers to provide health insurance for employees who work at least 20 hours a week. Lots of people don't have the option of obtaining health insurance through their employer. Someone may work at a place that doesn't offer health insurance, or an employee that may not qualify for coverage, or the person might be self-employed. Consequently, some people purchase health insurance through what is known as the insurance individual market. That's a plan that the individual purchases directly from an insurance company and not through their job. About 9% of privately insured individuals, about 25 million people in the country, buy health insurance products on their own in the individual insurance market. Next slide. Insurance isn't cheap, and it's especially not cheap if you need coverage for yourself and your family. Premium costs for single and family coverage in the private market have outpaced inflation and are now topping about $5,000 for single coverage and $15,000 for a family policy. And as the costs of these premiums increase, the percent that the employer is willing to pick up has been steadily decreasing. Next slide, please. One of the reasons that the costs of private health insurance have been growing so much is that the commercial sector may be indirectly subsidizing the cost of caring for the uninsured. With about 50 million uninsured, hospitals and especially emergency departments, physicians, clinics, other health professionals are all providing some levels of uncompensated care and then shift some of the costs to these uninsured individuals to those who are insured. The situation can get very complicated for a clinician or other healthcare provider who sees patients who 1 month the patient might be privately insured, next month the patient's uninsured, several months later the patient might be on Medicaid. And I'm sure that those of you who work in the emergency department see this all the time. These disruptions in coverage mean that many more people are uninsured at some point over the course of any 2 to 3 year people. And added to the 50 million uninsured are millions more people who have very limited insurance coverage. These are the underinsured. It's not unusual to see people with high deductibles, even up to $5,000 deductibles. These are the people who are covered for catastrophic events but have to pay out of pocket to see a doctor, to get preventive services, to fill their prescriptions. Lots of times, these insured people will just avoid or delay getting care. They end up in the ED often with costly and complicated problems. Next slide, please. So now let's get to what changes under health reform. The ACA includes a broad set of rules to protect insurance coverage. Insurance companies can no longer deny coverage for pre-existing conditions and cannot set lifetime limits. Pre-existing conditions can refer to just about anything: cancer, diabetes, asthma, orthopedic problems, you name it. The way the system currently works, you may be able to purchase a health insurance policy, but the insurance company routinely excludes your condition and any services related to it, which is exactly why you need the insurance in the first place. These types of pre-existing condition exclusions are very common in that individual insurance market I talked about just before, but they are gone as a result of the ACA. Insurance companies can no longer set lifetime limits on coverage for certain conditions or health needs. Insurance policies now routinely set these lifetime limits, which can sound very generous. For example, $1 million limit on coverage for any given condition might sound pretty good, but in fact, for people with very complicated and chronic conditions, racking up $1 million in healthcare costs can happen in a matter of a few short years. So these lifetime limits are also gone under the ACA. The ACA limits the ways that the cost of insurance premiums can be set. Under health reform, premiums can vary according to 4 and only 4 different things: the insured person's age, whether the insurance coverage is for single person or family, the area of the country that the person lives in, and whether or not the person smokes. I see that I worded the slide incorrectly. The cost of the policy doesn't vary by the number of family members. It varies by whether it's an individual or family policy. The cost of the insurance does not vary by the number of children in the family. And speaking of children, the ACA allows young adults up to age 26 to remain on their parents' health insurance plans. Some of you may have heard that some insurance companies recently issued rebates to their enrollees. This is because the ACA sets requirements related to the medical loss ratio. That's the percent of money the insurance companies take in that actually goes to health services. The ACA sets the medical loss ratio at 85% for large group plans and 80% for companies covering individuals and small businesses. If an insurance company ends up spending less than their required amounts, it has to pay the difference back to its enrollees in the form of a rebate. And this provision went into effect very soon after the ACA was enacted, and more than $1 billion was paid back to health plan enrollees in the first round of rebates. All of these insurance reforms take place within the context of a new private health insurance market called health insurance exchanges, which we'll talk about more in a few minutes. The federal government will help people purchase insurance by providing subsidies for individuals and families with household income up to 400% of the federal poverty level. The federal poverty level is based on family size, so the larger the family, the higher the level, which reflects the fact that the larger the family, the more money the family needs to cover the basic necessities in life. In 2012, the federal poverty level is set at about $11,000 for an individual and about $22,000 for a family of 4. That means that the federal government will help people purchase insurance for individuals who have up to about $44,000 in household income, and for a family of 4 who have up to about $88,000. The subsidy gets smaller as the income level rises, but these subsidy levels recognize that insurance is very costly, and the overriding policy goal is to get everyone covered. One of the most important features of health reform is the establishment of a minimum level of coverage. The ACA sets a minimum level of what's referred to as essential health benefits that all but a small set of health plans must provide. When people sign up for health insurance, and this applies to health insurance in these new markets, people will choose one of 4 benefit tiers: bronze, silver, gold, and platinum. All of these levels must include the set of benefits that are deemed essential for any health insurance plan to provide. The new insurance markets really are targeting people who are between 133% of the federal poverty level and 400% of the poverty level. That 133% refers to the new threshold for eligibility for the Medicaid program, and we'll talk about that in a minute. The new insurance markets are also available to people whose employers don't offer health insurance, and people who work in firms that offer health insurance, but the cost to the employee is deemed unaffordable, which according to the ACA is set at more than 9.5% of the employee's income. Small businesses, which are those businesses that have fewer than 50 employees, can also purchase health insurance through these new markets. But these markets are not open to larger employers or to other employees who can get insurance through the workplace. The ACA does not move existing employer-sponsored health arrangements into these new insurance markets. Next slide, please. I think just about everyone has heard about the individual mandate, the ACA's requirement that everyone must have health insurance. The original estimate for new private health insurance coverage was that about 16 million people who were previously uninsured will get health insurance as a result of the law. These estimates are a little higher since the Supreme Court decision, with the logic being that employers and the new insurance markets may enroll some more individuals than was originally anticipated. The requirement to purchase health insurance will be administered through the tax code. The penalty for not obtaining health insurance is actually a tax, according to the Supreme Court. The individual mandate provisions begin in 2014. When you file your 2014 federal tax return, you'll have to answer a new question about whether or not you have health insurance. If you answer yes, you'll be asked to provide some information about the coverage, the plan name, policy number, for example. If you answer no, you'll need to calculate the penalties that apply. Again, this is a requirement through the tax code, not a requirement punishable by criminal penalties. You may choose to remain uninsured, but you'll be taxed on that decision. During the first year, the penalty is low, $95 per person or 1% of taxable income. The penalty reaches the full amount beginning in 2016. At that time, the penalty is $695 per year, and that's for one person, up to a maximum of 3 times that amount for the family, or just under $2,100. Or, so there's a penalty for an individual of $695 up to a family of $2,100, or 2.5% of your household income, whichever is greater. So it's the greater of those two amounts. This requirement applies to U.S. citizens and to legal residents. There are exceptions to the mandate, which you can see that are listed on the slide. Next slide, please. The ACA places the insurance-related mandate squarely on the shoulders of individuals and not employers. But that doesn't mean that employers are off the hook. Many employers that don't offer health insurance will face substantial fees. And these fees on employers are only for employers with 50 or more employees. Small employers that do not offer insurance will not be subject to these fees. But if an employer with 50 or more employees does not offer health insurance, and one or more of its employees takes advantage of the health insurance subsidies, then the employer is subject to a fee, and these fees are pretty substantial. Employers with more than 50 employees face the following scenario. If just one employee takes advantage of a subsidy and purchases a subsidized plan, the employer must pay a fee equal to $2,000 per employee, and that applies to all employees. If an employer offers health insurance but one of the employees takes advantage of the subsidy, meaning that the cost of that insurance exceeds the 9.5% threshold of income for the employee, then the employer must pay a fee of $3,000 per employee who gets the subsidy and $2,000 per employee who does not. The fees don't apply to the first 30 employees, and that cushions the blow to medium-sized employers. But the impact will be substantial. The goal here is to incentivize employers to include health insurance as a covered benefit. Next slide, please. I've mentioned these new health insurance markets several times. The ACA refers to these as health insurance exchanges. The goal is to create a portal. When I say portal, imagine a website that allows you to do one-stop shopping for certain types of products. This portal will enable people to shop for and sign up for health insurance that's easy to understand. Exchange websites will also allow people to determine whether they qualify for a health insurance subsidy and what the size of that subsidy will be. The exchanges will be administered by states. They're completely voluntary, and states can choose not to set up an exchange. If a state doesn't want to set up its own exchange, there'll be a federal exchange for individuals to learn about the same information, options for health insurance coverage in their state, find out whether they qualify for subsidized health insurance, and they'll be able to enroll through that federal portal. And the exchanges may be completely voluntary, but the requirement to have health insurance is not. Whether your state has an exchange or not, individuals and businesses across the country are subject to the very same requirements, subsidy levels, penalties, and fees. And the ACA does not include a public plan option. Next slide, please. The ACA sets a minimum level of benefits that health plans must provide to be deemed qualified to do business. All plans must provide, at a minimum, the 11 categories of benefits that are shown on the slide. The essential benefits must be included in all plans. There is also a catastrophic option for people up to age 30 or people who are exempt from the individual mandate. It allows them to purchase a less expensive plan with a higher deductible. But these catastrophic plans must comply with the requirements to make certain primary care and preventive services available and not subject to the deductible. Just to repeat, these catastrophic plans are not available to people over 30 and also not available to people who fall under the individual mandate. The different tiers that I mentioned, the bronze, silver, gold, and platinum, reflect variations in cost sharing and not differences in the essential benefits that have to be included. Next slide. The ACA also makes changes to Medicare, although they're less sweeping than the laws changes to the private health insurance market and to the Medicaid program. So Medicare is a federal health insurance program that provides coverage to over 47 million people. Most people covered by Medicare are elderly, about 39 million Americans, but nearly 8 million others qualify for Medicare because they're considered permanently disabled. The Medicare program has been the topic of a lot of debate and discussion. It's very popular, but it's also very large and costly. Enrollment is growing and expected to reach nearly 80 million by 2030. That's a doubling of enrollment from the year 2000, and it represents about 15% of federal spending, or about $550 billion in 2011. Next slide, please. The health insurance expansions that are included in the ACA do not pertain to Medicare. Medicare already covers nearly all elderly in this country. I'm just looking to see, I think you might have skipped a slide. Can you go back one, please? Okay, thank you. Beginning in 2011, the ACA requires Medicare to provide free annual comprehensive visits, wellness visits, and adds other free preventive services identified by the U.S. Preventive Services Task Force to be necessary and grounded in evidence-based medicine. Some of the costs of health reform will be paid for through savings from the Medicare program. The biggest chunk of this comes from cuts to payments associated with Medicare Advantage, which is Medicare's managed care program. Medicare Advantage is a voluntary managed care option that about 1/4 of Medicare beneficiaries enroll in. Medicare has been paying these plans more than what other beneficiaries cost, so the cuts normalize payments to be more in line with other Medicare spending. And the ACA also gradually eliminates the so-called donut hole in the Medicare prescription drug program by the year 2020. The donut hole refers to the gap in coverage that occurs when people who purchase prescription drug coverage from Medicare reach a certain level of drug utilization, and they're then required to pay 100% of the cost of their drugs. Next slide, please. Here it is, there. Reining in spending under Medicaid will be very tough, and one that will not be addressed in a comprehensive way in the ACA. Medicare is a growing program, in part because of the demographics of our country and an increasing number of enrollees. The basic foundation of any social insurance program like Medicare depends on shared responsibility. Younger workers pay into the Medicare program through payroll taxes, and the Medicare beneficiaries receive benefits, but also share in the burden in out-of-pocket costs. And in fact, Medicare beneficiaries pay about 1/4 of the cost of the program through these out-of-pocket payments. What this slide illustrates is the challenge of maintaining a program like Medicare with a rapidly growing covered population and a dwindling number of workers per beneficiary who support the program over their working years. Next slide, please. Despite its name, the Affordable Care Act does not eliminate the cost problem. If Medicare spending stays on its current trajectory, like other sectors of the health economy, its growth will eventually be unsustainable. And there are other problems. Medicare faces looming cuts to physician services. The Balanced Budget Act of 1997 included a series of cuts to physician payments that have largely been pushed back for well over a decade. The cuts haven't gone away, though. They've been deferred. And just like interest on a credit card, they keep piling up and piling up. Physicians now face cuts in the 30+% range, an amount that, if implemented, could cause many physicians to walk away from the Medicare program altogether. Next slide. For all of these reasons, the ACA includes changes to Medicare that will cut costs, including payments to providers. We talked about Medicare managed care plans, also hospitals, clinical labs, other cuts. The ACA also includes initiatives designed to incentivize better, more efficient, and safer care. You may have heard of accountable care organizations, or ACOs. These are groups of doctors, hospitals, and other healthcare providers who come together to give coordinated, high-quality care to their Medicare patients and share in the savings from providing highly coordinated care. Medicare is now operating several demonstration projects with different types of ACOs. Some ACOs are opting for a higher level of shared savings and agreeing to be at risk for any losses they may occur. Medicare is also experimenting with payment reform by paying certain hospitals and doctors global payments for all the services associated with a condition. That is, paying for a clinically defined episode of care. And there are certain things that Medicare is not paying for. For example, Medicare will not pay for readmissions within 30 days for patients who present with certain conditions. The ACA penalizes hospitals with higher than expected readmission rates beginning in 2013. The initial focus here is on readmissions among patients with heart failure, AMI, and pneumonia, with the penalties for exceeding readmissions targets growing from 1% of total inpatient charges in 2013 to 3% in 2015. And these provisions will extend to other conditions. Much of this experimentation is taking place through a new Center for Medicare and Medicaid Innovation, which will invest about $10 billion over a decade to test and evaluate all sorts of health sector innovations. Next slide, please. Now we're going to turn to the Medicaid program, which covers about 60 million people and is without question the most critical source of support for low-income people in this country. And it is the engine that supports the healthcare safety net. It covers about 30 million poor children and about half as many low-income adults in low-income families. It also covers about 14 million of the nation's elderly and people with disabilities. 1 in 5 Medicare beneficiaries is also covered by Medicaid because they're poor or disabled, or usually both. And it's the single most important source of support for nursing homes and other long-term care in the nation. The costs of Medicaid are shared by the federal government and the states, with the amount varying by state based mostly on how many poor people reside in the state. On average, the federal government picks up about 57% of the costs, and the state pays about 43% of the costs. Next slide, please. As you can see from this slide, children represent about half of the enrolled population in Medicaid, but represent less than 20% of the cost. This makes sense because kids are generally healthy, and they cost less than adults and the elderly. Adults who are covered by Medicaid, and these are all adults with dependent children, make up about a quarter of the covered population. But again, they're also not as costly a population. It's a whole different story with disabled and elderly Medicaid enrollees. This is the same dynamic that plays out in Medicare. The disabled make up a relatively smaller portion of the program, in this case 14% of Medicaid, but represent 42% of the costs. Next slide, please. So what's happening with the ACA in terms of Medicaid expansions? Well, let's talk about what the law said, and then we'll talk about what actually might happen given the Supreme Court decision. The ACA includes a major expansion of the Medicaid program, and for the first time pegs coverage almost exclusively to how poor the person is. Beginning in 2014, states would be required to extend coverage to residents with incomes up to 133% of the federal poverty level, and this is a major change to the program. Currently, being poor is not enough to qualify for Medicaid. That's because Medicaid includes a limited set of categories to be eligible for coverage, in addition to being poor. The categories are children, pregnant women, adults with dependent children, disabled individuals, and some poor elderly. The income eligibility levels are very different across these different categories. So, for example, adults with dependent children must be very poor to qualify. On average, they can have income only about 50% of the federal poverty level to qualify. Adults who do not have dependent children are not eligible for Medicaid. Does not matter how poor. Adults without dependent children are not currently eligible. Now, the original estimate for the Medicaid expansion was that about 16 million people would be eligible for coverage through Medicaid as a result of these changes in eligibility. The ACA requires states to maintain Medicaid levels prior to 2014. This provision guards against states reducing their covered population and thereby qualifying for higher federal matches when the health reform kicks in. But the ACA includes a maintenance of effort requirement that says that if the state covered a certain group of people when health reform was signed, the state must continue covering that group until the coverage expansion begins in 2014. The ACA also included a provision to increase Medicaid payments to primary care providers over the period 2013 to 2014 to 100% of the Medicare payment level, with the federal government picking up the full cost of the difference in the payment. Not the full payment, but the difference in the payment. The goal here is to encourage more primary care providers to see Medicaid patients. Now about 2/3 of PCPs accept Medicaid patients, and this increase in reimbursement levels may help to get that number to over 80%. Next slide, please. You'll recall that the federal government pays, on average, about 57% of the cost of Medicaid services, the state paying about 43%. Under the ACA, the federal government will pay 100% of the costs of the newly insured under Medicaid in the years 2014 to 2016. The federal share begins to decrease in 2017, with the federal share stabilizing at 90% in 2020 and beyond. These higher match rates apply to the newly insured only. States will continue to receive their regular match for those groups who would qualify for Medicaid prior to reform. States don't need to wait till 2014 to start enrolling more people in Medicaid, but the higher match doesn't begin until 2014. Next slide, please. The Medicaid expansions that I just mentioned do not change Medicaid policy on the coverage of immigrants. Legal residents have a 5-year waiting period before they're eligible for Medicaid, and this waiting period does not apply to legal immigrants who get coverage through the health insurance exchanges. Undocumented immigrants are not eligible for Medicaid now. They will not be eligible for Medicaid under health reform. They are also ineligible for state exchanges. So this means that millions of immigrants will continue to be uninsured and face challenges finding affordable health care. Next slide, please. Who are the populations most likely to benefit from the Medicaid expansion? Most poor children already covered under Medicaid are already covered under Medicaid or CHIP. Pregnant women also tend to have coverage at levels that exceed those in health reform. These groups will continue to have Medicaid coverage at the same income eligibility levels under the same matching rate that the federal government currently pays. Where the biggest gains will be realized is for adults, working parents, non-working parents, and childless adults. These are the nation's poor who have not been able to find any affordable coverage. Next slide, please. Well, maybe they'll be able to get coverage. As you all know, the ACA was the subject of a recent Supreme Court case. As background, several states filed lawsuits to block the health insurance expansions. The case, known as the National Federation of Independent Business versus Sebelius, was argued in front of the Supreme Court in March of this year. Decision was rendered on June 28th. The court agreed to hear arguments on 4 issues, and those are listed on the slide. Next slide, please. On June 28th, the Supreme Court of the United States affirmed the broad constitutionality of the ACA. The individual mandate was deemed constitutional, not under the Commerce Clause, but under the federal government's authority to tax. The Supreme Court found the individual mandate to constitute a tax, and so left unchanged all parts of the law except one very important provision. The ACA originally gave the Secretary of HHS the authority to withhold all Medicaid funds if states chose not to comply with the expansion. The court found the Medicaid expansion to be coercive, determined that the Secretary of HHS in fact did not have the authority to withhold Medicaid funds if states chose not to expand. So right now, it's not clear what this means for states that want to take up only a partial expansion. In other words, whether states will have to choose full expansion or no expansion. But it's clear from the Supreme Court decision that states do have the right to take a pass on the Medicaid expansion and continue to receive federal matching dollars for their current Medicaid programs. So what's the effect of the decision on coverage? Well, it's hard to guess, especially now we're so close to a presidential election and other local and state races. A number of states have indicated that they're moving forward with their expansions. Others have indicated they absolutely will not participate. About half of the states are undecided, and clearly the elections could change even those who've indicated a strong preference on either side. Two respected organizations, the Congressional Budget Office and the Joint Commission on Taxation, estimate that about 3 million fewer adults and kids will be covered under Medicaid. Other estimates put the numbers closer to 5 million fewer Medicaid enrollees. At least in the short term, it's pretty clear to say that the Supreme Court decision will have a dampening effect on new Medicaid coverage. But in the long run, if the ACA otherwise stays intact, and if history repeats itself, I think the states will eventually take the expansion, since doing otherwise would leave millions of people uninsured and, perhaps more importantly, billions of available federal dollars on the table. In the year after the passage of Medicaid, only 6 states signed on. In the year following the passage of CHIP, only 8 states signed on. The CHIP is the Children's Health Insurance Program. Now all states participate in both Medicaid and CHIP. Next slide, please. As the states think through their decisions about the Medicaid expansion, other provisions of the ACA are already taking effect, with important consequences for low-income people and their ability to get health services. These involve changes to the healthcare safety net, a term that commonly refers to healthcare providers who serve large numbers of uninsured and publicly insured patients. Community health centers serve a critical role in the safety net, providing primary care and preventive services to millions of patients all across the country. As the number of insured individuals grows, demand for health services is likely to increase. And for this reason, the ACA includes a large increase in funding to expand the number of community health centers and increase primary care capacity. The goal is to double the number of health center patients so health centers can serve about 50 million people. The ACA also includes cuts in payments to the safety net in the form of cuts to the disproportionate share hospital program, all commonly referred to as DSH payments. DSH payments support hospitals with lots of poor, uninsured, and Medicaid patients. With many more poor people qualifying for coverage, the ACA reflects the assumption that these payments will not be as critical to offset the cost of uncompensated care. The ACA cuts DSH payments in the Medicaid program by about $18 billion over a 7-year period, and these are really dramatic and deep cuts. It's not clear how safety net hospitals will fare without these payments, especially in states that choose not to expand their Medicaid programs. Next slide, please. So the ACA does have a clear emphasis on wellness and prevention to keep people healthy and avoid the need for costly care. Coverage will include more preventive care that's free at the point of service. This includes contraceptive services. Medicare beneficiaries can get a free wellness exam each year, and small employers can receive incentives to establish wellness programs. The ACA also establishes a public health trust fund with a multi-billion-dollar investment in prevention research, health screenings, immunization programs, other prevention and community health-related activities. And some of you may have noticed that chain restaurants are now disclosing the nutritional content of their offerings. That's a result of the requirements in the ACA. Next slide, please. A few weeks ago, the Institute of Medicine, which is the health arm of the National Academy of Sciences, issued a report that estimated that 30% of health spending could be cut with no decrease in quality. What that translates to is about $750 billion a year. Well, how could that occur? According to the Institute of Medicine, these reductions could occur from a completely re-engineered healthcare system that includes the best of technology, system redesign, evidence-based medicine, and advanced health information technology. Such types of changes could result in better care, with a lower cost, more efficient health system that provides more equitable care for everyone. So one scenario for the health system of the future is a leaner, better functioning, and fairer health sector. The ACA is a critically important step toward that future, with provisions to expand coverage, reform the insurance market, increase capacity in terms of primary care and prevention, and spur innovation for quality and efficiency. Thank you so much for your time, and with that, I will turn it back to you, Juliana.
Thank you, Marcia. And now I'd like to turn our presentation over to Mike Williams.
Hello, everyone. It's Mike Williams, president of the Abaris Group. Pleased to be with you today and to talk to you about taking this very challenging topic area with lots of dimensions that Dr. Regenstein helped us walk through and understand to applicability at how it affects you at the EMS, the emergency department, or the trauma fields. Now, I have noticed a few questions that have come in. Julianne, I don't know if you want to take those now, or maybe I'll get started here, and you want to get oriented to some of those, as I believe all of those will be for Marcia. Let's go with the next slide. So basically, what are we talking about here? Well, you know, what does success or failure mean with respect to health reform? And I like to think failure is likely to be having something imposed upon us and waiting for something to happen, and not understanding the program, including even all the dimensions that Dr. Regenstein mentioned, or the balance side is being successful and embracing the opportunities to provide with you know, up to 30 million new insured people, and the impact it may have on our delivery systems, and really the very strong message the Institute of Medicine has given us recently about the amount of waste and inappropriate costs that are going on in our healthcare system. Next slide, please. All right. Well, you know, in some cases, failure here would be the people that actually literally left and run, literally without the shirts on their back. Next slide, please. I don't think any of us want to be guilty of that, so I think success is really preparing for the future of emergency care in the environment of health reform, and really, as I said, embracing it and understanding its features, and then moving forward with strategies that really don't have health reform come to us and are imposed upon us, but really us taking the lead, us being the providers and the systems and the planners, and moving forward with specific strategies. Next slide. So I think one of the early elements of this topic, you really have to understand where the premium dollars get spent. So this would be a fairly standard average payer spending plan. And you can look down below there on the left side, national averages, hospitals spend basically expenditures are about 33 cents of every dollar. Physicians and other clinical services about 30 cents. Prescription drugs about 13%. Dental services 6 cents. Other professional services 2 cents. Nursing homes, and then home health care, with about anywhere from 10 to 15 cents spent on the cost of running the health plan. And as Marcia told us here just moments ago, that's now going to be capped under health care reform. The payers are no longer going to be able to charge more than a certain benchmark for what they call their non-direct services, that is their overhead. Next slide, please. I think it's important to recognize that we are a mere, return back if you don't mind to the side, we are a mere small percentage of that entire expenditure. It is estimated that emergency departments alone are less than 1 cent of the total premium dollar in terms of expenditures. And if you want to go to EMS, it's less than 0.1 cent for EMS costs. So one of the reasons why in EMS we're kind of asking the big question, what is this health reform thing and what does it do for us? Is for many payers, you're not even on their radar screen. And that's important to know because so many of the innovations and the financial incentives and disincentives that have occurred in our country and with healthcare have not really hit us in the emergency EMS, emergency department of trauma center arena with a small exception to the emergency departments. And therefore, all of this is sort of brand new to us. In some respects, that's a good thing, having not had that imposed upon us in the years prior. But in a sense, it's a bad thing because we're likely to have that imposed on us in the future. Next slide, please. So the one thing we should be aware of, and it won't take long for payers to understand this, some payers even know this already, that even though we derive less than 1% of the total expenditures, dollar expenditures in the country for health care, we probably drive specifically 60% of all the costs. But for the EMS delivery system and the delivery of that patient to an emergency department, right? We're on autopilot on that, right? We have to take these patients to emergency. And but for the emergency department that is legally bound under MTALA to work these patients up and screen them using all ancillary tests, we might not absorb some of these costs. And it turns out that some of these patients will actually get admitted. And some of those that are admitted, on retrospect, may not have needed that admission. But that's just the way our system is set up. So while you're less than 1% of the dollar expenditures, you probably drive 60% of overall health care expenditures. Next slide, please. So here's what we know, and this is probably the $64,000 question that you all have been asking. How is health reform going to affect us? There's a lot of innuendos, there are a lot of rumors, and there's a lot of misunderstanding. And so let's correct those with 3 simple bullets. It is not likely that EMS responses will grow in response to health reform. So we expect ambulance responses to continue to grow as they have, but organically. That is based on primarily population and demographic basis, not based on payer status. And it only makes sense, right? How many calls that are triaged at dispatch and go through emergency medical dispatch, for example, that where the question of payer source is asked? How many people at home do you think consciously make a decision to call an ambulance because now I've got insurance? It just doesn't happen. It's very rare. And there might be certain social demographic groups where there's a bias that you think drives, but overall, in terms of the overall response system, it just has not happened. Now, we have no literature or scientific evidence of this, of what we do know about health reform, but we know intuitively and from the many studies that the Abaris group have done, it's not likely to grow exponentially, which, by the way, is a big worry to EMS, the EMS industry. I've heard what little we have on this subject of health reform and EMS is almost all concentrating on increased responses. And to be frank, it's the Abaris group's opinion that that is not likely to occur. Emergency department visits will, again, grow organically, not large surges. And so, again, that's a pretty big bias that most have. Now, this one we do know from the literature because Massachusetts has had health reform at a similar level for about the last 4 or 5 years, and the literature suggests that they have not seen an increase in emergency department visits over time. So we're not expecting that piece of it to grow, again, beyond the, sometimes 3 to 5% growth rate that's been occurring in communities across the country. What about trauma centers? Again, your patients are likely to grow organically, and in some cases that's been a flat growth, but I'm in a community today in the Midwest where they've seen substantial increases in trauma patients just over the summertime that they cannot believe. In some cases, with programs that's 10 to 15 years old that are saying they're seeing the largest volumes per month they've ever seen before. But having said that, that's very locally based, but not, and specific to the facts of that area, but not really based on facts as it relates to health reform. So what we do know is that health reform is largely going to impact the primary care network. And one may say, well, gee, because the primary care network is going to be overloaded, they're going to ultimately select to go and use EMS resources, emergency department sources, or maybe to a smaller degree, your logic would take you to trauma centers. But the fact of the matter is we have not seen that, particularly in Massachusetts. So those that do not get care are likely to try to seek out care now. And I can tell you on a balancing standpoint, we've seen a rapid growth in urgent care centers across the country, and we're expecting to see a whole more growth in the future. And a lot of those are being built on the model that, hey, if primary care office visits are full, maybe we on a retail basis can offer these. So you can see in some markets large number of drugstores that offer what they call retail medicine. You can actually walk in and get seen by a nurse practitioner within a couple minutes and be out of there in less than 15 minutes. So that's likely what we're going to see more of, is more retail. You know, with these people being insured, why would you not want to, why would the market not reach to those people? And the bottom line is we believe that's true. So let's just debunk all these myths and move on to some other challenges that we know about the industry. So next slide, please. Well, we do know that it's likely up to 39 million newly insured. That number is from the Kaiser Foundation. I think previous number we said about 30 million, but you know, the exact numbers are not exactly known, but it's a large percentage of the 50 million uninsured today. So the last report showed about 49.9 million people uninsured, and about a very large percentage, somewhere in the 30 to 40 range, will become insured. And it's interesting to note, it will differ depending on different communities, but about only 43% of that was likely to be predicted at the national level to be Medicaid, and about 57% using what we call the insurance exchange, but we also think of that as, you know, AKA relatively traditional insurance, the Blue Cross, the Aetnas, the Health Nets, and things of this nature. So a large percentage of this newly insured will be insured under a truly insured product, something that, frankly, most markets go after. And we expect to see a large interest in the Medicaid population as well by those that are in a position to grow products for the Medicaid population. Why? Because for the most part, Medicaid represents an incremental expense, not a startup expense for a health hospital or a clinic or what have you, and therefore likely to be worth going after, because it does, while it doesn't pay very well, it does pay something. Now, the emergency industry, that's a little different. So while we're going to see a big increase in the insured, what's the collateral or contrary fact that we know? Next slide, please. A very large piece of how we're going to pay for health reform is going to be in health care cuts to Medicare. About $716 million will occur in the next few years. Excuse me, it should, that's a typo. That should say $1 billion. And so we're going to see a massive, over a 20-year period, reduction in expenditure in Medicare. And while the actual framework and details of that are not well known, there have been some efforts, including things like for emergency departments, sustainable growth rates, and other things been put into place to attempt to put a lid on physician costs, and in many cases, emergency departments and hospitals in general. So now, how are we going to pay for all this? It's going to be through cuts. So where those cuts are likely to be is pretty well directed if you shine the spotlight anywhere where healthcare is going right now. Next slide, please. And what we do know from what Dr. Regenstein has quoted, the Institute of Medicine last week came out with a landmark study titled Best Care at Lower Cost, a Path to Continuously Learning Healthcare in America. And while a large part of this whole study emphasized innovations in IT and what have you, they did find that basically a third of the healthcare expenditures, roughly $750 billion, were wasted on unnecessary services, excessive administrative costs, fraud, and other problems. And so to a certain degree to say, well, gee, we're going to have to lower our reimbursement completely is a relatively myopic view of this, because we think most of the cost savings is likely to be created through cost efficiencies, and more importantly, more efficient and effective ways of delivering patients to within our system through the entire patient care transition process. So are there any opportunities in emergency care? Well, you bet darn well there are. Next slide. One thing we have, and I want to thank our friends at MedStar in Fort Worth, EMS delivery system there, that has done quite a bit of work on the community health professional called the Community Paramedicine Program. it's sort of a nature of what we are caught in. We're caught in this sort of absolute compromise cycle, because they call it the vicious cycle, where the underserved, they lack primary care, they get poor coordination, they lack transportation services, and these are the poor, by the way, poor follow-up, decreased health status, and guess what? They frequently come to the EMS and emergency department services. Well, we don't see a big use of that. Wouldn't it be smart to get ahead of that power curve? Even though many of these new people are going to be insured, there may still be some of these old behaviors. So again, not expecting a big increase in this, but if those are inappropriate resources, then I think we should consider moving forward with that mantra. And let me take a quick pause here. Juliana, are you ready for a few questions?
Yes. We have one question from Phoenix, Arizona for Marcia, asking, what will the penalty money from the ACA be used for, Marcia?
Well, it's through the tax, so it's in general revenues. So it's going to be used, those penalty amounts are not necessarily earmarked directly for a specific program, but they're going to be generally used to support subsidies or other costs of health care. Sorry?
That was me, I'm sorry.
Very good, and thank you for that. And Mike, the other question we have is, you had a slide that showed emergency care providers drive 60% of the costs of their patients, and someone wanted to know, where did you get that source for that piece of data?
Well, I think it's an estimate. We've done a lot of work with EMS providers and emergency department trauma providers, but we've also been fortunate enough to do a lot of work for health payers. And to be frank, one of the scariest thoughts to a payer, a Blue Cross or a Health Net or what have you, is a patient going into the emergency department. They see that patient going down a big black hole. And what they find is, we say the most dangerous tool in an emergency department is, guess what? The pen, the order, the tests that are ordered, and all the things that are perceived by the payer as being unnecessary. And to a certain degree, we have some of that in emergency department care and in EMS in general about transporting our patients. We'll see some more slides about this in a minute. And having said all that, we believe from the payer experience we have that it does drive about 60%. Patients don't get admitted to the hospital unless they come through the emergency department, by and large, on an urgent basis. And guess what? A large percentage of those patients on an urgent basis come in through EMS. So we are truly the portal for a large percentage of the expenditures in the country.
Thank you. I'll let you know if there are any other questions.
Gotcha. So let's move on. Next slide, please. All right, so I want you to think of waste, and it's okay to, wallow in waste here for just a minute and think about where the opportunities are given the IOM's recent report. And remember, the IOM came out a few years ago with the Future of EMS emergency care reports that were very seminal and resulted in a number of changes in federal leadership on emergency medical care, and really pretty much a strong endorsement of our EMS, our emergency department, and our trauma system across the country on the basis of the capability and the outcomes they produce. But moving forward now with this new message of $700 billion worth of waste, where do we weigh in on this? Next slide, please. So think about EMS waste. So, when we think about EMS waste, we think about, okay, we're sending everyone. We're sending them to everything, regardless of needs and outcome. And if you think about that, most of our EMS delivery system in the country, really, this is pretty much their default. A call comes in, you respond. You might sort that call, that EMS call, based on certain kind of resources will be sent, and you're certainly going to sort, almost everybody is sorting based on pre-arrival instructions that you might give, but pretty much you get what we call the full court press court, which is, an engine response in many communities in this country. You get ambulances. Occasionally, if it's a multi-patient scenario, you'll get a supervisor. And I'm working in a community now because of the configuration of fire departments, a big urban community, and various protocols they have. you could get up to 5 pieces of equipment on a simple medical call. So that's a lot of resources to people that, by and large, may not need all those resources. So think about EMS waste. Next slide, please. Well, think about emergency department waste. Well, first of all, we have a very high cost structure in emergency departments, and while there have been some studies to show that incrementally costs for new emergency department, and especially lower acuity, are pretty low, by and large, an emergency department is expensive to run. So for the most part across our country, we don't really have a low acuity model. And if you look at, and we've recently studied this, we've done many studies in this nature, but we just studied it for the same large urban community that we're talking about, we found that 40% of all emergency department visits using a national approved algorithm did not need to be in that emergency department. More importantly, could have used a lower acuity, more timely, I say time in the sense of more protracted time, care model. And these are nationally accepted criteria and diagnosis structures that drive that model. So if you said 40% of them need to be there, what do we do with these patients? Well, for the most part, we put everybody through the same machine. Now, there are a number of emergency departments in the country now that are looking at provider up at what we call provider triage. They're not really triaging. They're sorting patients based on a medical screening exam model. But the fact of the matter is we really don't have a lower acuity model in most of our emergency departments. They're based, they go through a machine that requires and has the risk of ordering a lot of tests. And when you look at the actual emergency department patient that comes by EMS, and you look at how many of those get admitted across the country, our studies have shown that only about 46% of all those EMS patients ever get admitted to the hospital. And less than 20% on average get admitted if they come through the door. So it's really not a model that is sustainable if you really start pushing back on waste. With the I'm calling for a fundamental re-engineering of the healthcare system. Also, the other thing we know is we have tremendous variation of our caregivers. For example, over-ordering a test. And you say, well, I don't think we have any ordering of tests that aren't necessary. Well, you all know who they are. Every emergency department I go into, I'll find out generally within about 3 or 4 minutes who the top 2 or 3 physicians are that tend to order everything. We call them the $1 million workups, right? Well, where did that term come from? It didn't come from me. It came from nurses working in the emergency department. And they'll walk in on a shift and they'll shake their heads and say, oh my God, Dr. So-and-so's on and Dr. So-and-so's on. And, basically they're talking about, a slow physician who tends to order everything and maybe doesn't even order everything at once, but orders everything over time, serially, because, they can't really figure things out. And then all of a sudden at the end of the shift, they get an epiphany and suddenly that patient gets dispoed. So it's really important. When you look at that variation, if you line physicians up and their testing model, just use CT test as an example. If you actually looked at the number of tests per 1,000, you'd see a lot of variation between your emergency physicians. And CT is pretty much under the microscope right now, but there's a lot of evidence now to suggest that we order too many tests, CT tests in the emergency department, and more importantly, there's some radiological risk associated with these tests. Having said that, what does a CT scan take? It takes at least an hour if you can get an interpretation in a short period of time, and often 2 to 3 hours. Episodic care, well, our emergency department is based on episodic care, and so we have to realize we're not really solving the whole patient's problem. An emergency department is an event in time where patients get care for their episode and they get sent home. They don't get primary care, and many times they don't get reintroduced back into the primary care system, which really health reform ultimately should be encouraging to do. Next slide, please. And then trauma centers, well, to be honest with you, we're just school kids, right? We're not going to tell anybody publicly this, but, do you think there's any excessive triage in our system? In fact, we bank and measure appropriate triage in our trauma system, of triage of seriously injured patients at trauma centers. These are big, expensive, regionally placed centers. And we think of them as, having over triage rates in the 25 to 50% level. In fact, there's literature that documents that. And you said, can we get any better than that? Of course we can better than that. Just think of the mechanism of injury, MOI, as a challenge. So many patients get moved to a trauma center based merely on mechanisms of injury, and I'm not poo-pooing that too much because I think there's an index of suspicion that we really do want to have. But I've worked in systems, big urban systems with lots of credibility, trauma systems, where, you know, for example, pediatrics is sent by helicopter all the way down to the pediatric emergency trauma center, only to have in excess of 50% of them discharged from the emergency department. And parents might be 50 miles away driving down to that emergency department. That's just unthinkable. That's just a lack of discipline. And with the science and capability and credibility that trauma centers bring to our table, we ought to be able to do better than that. And also, we pretty much have the welcoming committee, right? We send the entire trauma team on many trauma codes, even though some hospitals are now stratifying the number of people they send. But even so, those people are not gone. Their costs haven't gone away. They're just not responding to the code. And the question becomes, do we need all those people in the hospital? Many trauma centers freeze certain activities during the trauma resuscitation. For example, CT scans frequently go down or are stopped or are abated routine until the trauma patient is properly assessed and move through that. And the question then becomes, do we need all those CT scans? Do we need to paralyze the entire hospital over one event, or can we be more critical as it relates to our data-driven decision-making? And then looking again at low-yield ancillary testing, you know, having trauma panels is becoming more and more unacceptable, where you order 10 tests automatically as opposed to maybe ordering tests that are specific to that patient's condition. It's a concept that started 25 years ago, and maybe even close to 30 years ago, about automatically ordering all these tests. But now, you know, it's time to rethink these things. I'm actually working in a trauma system now, as I said, in the Midwest, where they keep 4 units of O-negative blood right in the emergency department in the resuscitation area. And I have to say that there's a certain comfort level of having that capability. And yes, there have been anecdotal cases in the last 2 or 3 years where all the blood in the world weren't enough. But the fact of the matter is, with the blood shortage across the country, the question really is that the most appropriate use of that blood services, particularly if there's any risk at all that blood supply expiring. Next slide, please. Next slide, please. There we go. Next one after this. Okay, so we're moving away, and this is the big change with, we think, what's going to come with health reform. Remember today, health reform, as Dr. Regenstein mentioned, is really insurance reform, but we think it's going to move to true health reform. We have to in order to achieve that $700 billion cost savings. And where that's going to take us, it's going to take us from being paid on a fee basis, which all emergency care providers are. They're paid on a fee-scheduled basis, by and large, and move them to a value-based system. Well, what does that look like? Next slide. A value-based system would take into account not only your costs, but what outcomes are you driving. So if we have over triage rates of up to 50%, if we have EMS calls that are being transported with less than a 50% admission rate, with lots of resources, if you just do the math, you're going to find that, by the way, by the nature of what we study, we're going to find that the value may not be there. And I think we could all criticize ourselves comfortably and quietly in the closed closet, but it may be time to come out of the closet and start thinking about these things in the open and doing a real reality check before somebody does this to us. Next slide, please. So this is just to put on the table. Marcia mentioned some of this, but I also want to mention this. Some of you have been through this, but when you look at quality measures for Medicare that really started, 2007, 2008, where they published some markers in every industry except our industry, emergency care, with the exception of emergency departments. We had hospital stakeholders, we have physician, we have nursing homes, we have farm, lab, rad. We have all these people at the tables commenting on their quality indicators. We had proposed rules that came into play in 2009, 2010. They adopted these rules with no penalty for the first year or two, and then we're now seeing incentives and disincentives that hospitals are literally, and medical groups are literally being challenged with if they don't meet certain markers on throughput or door to aspirin or even on some of the quality indicators of hospital readmission rates and things. They're actually being disincentivized. They lose money when they don't get the numbers right. And what is missing from this chart? Well, I can tell you emergency care by and large has missed most of this. Now, again, some of these rules apply for emergency departments, so I don't want to ignore that. But as a rule, emergency care by and large is being perceived as an entitlement, and really they haven't drilled down that much. But when the numbers begin to get published, and while we're less than 1% of the actual dollar expenditures, we control up to 60% of the actual healthcare expenditures. That's going to be a take notice, stand up. We should be looking at this kind of model, that automatic mindset of moving these patients through this system versus, wait a minute, folks, should we make a decision? And there are some programs in the country that are doing that now. Next slide, please. All right, so we have tremendous opportunity. I don't want to take, a very negative stance here. And we have so much anecdotal innuendo about emergency care and how it's going to be impacted by reform. And we now can take that opportunity and move it to a more precise data-driven models, delivery models that can be tested and verified and warranted and maybe even funded differently than we are today. Next slide, please. So think now, instead of waste, cost-effective, appropriate utilization, and data-driven outcomes. We've known for a long time, folks, that paramedic services, by and large, when you look at the actual impact of patient and outcome, by and large, have a lot of room to grow. I think that's as far as I want to take that one. And it's a dirty secret in our EMS industry, but we produce an awful lot of production of emergency care resources for patients that, by and large, a very small percentage of patients that will truly be impacted. And one can say when you're evaluating any particular patient that's ill or injured, that's a benefit of paramedic skill level. But on the other hand, what's the actual outcome? Do we change the outcome, and do we have a direct impact? Next slide, please. So one step we can take is to really begin to look at best practices in the industry, look at what some programs, and there are snippets of programs. This happens to be an ambulance, but it could be a trauma center, it could be the emergency department, and look to what they're doing and what the yield has been on some of these innovations. Medicare has now funded, as part of this $1 billion innovation grant process that they went through very rapidly at the beginning of the year and the latter part of last year, they funded at least 3 big projects, some of which they're spending in excess of $20 to $30 million per project on EMS innovations, looking at better enhancing the skill sets, getting care out in advance of emergency condition, looking at gatekeeping and case management and things of this nature. Next slide, please. And there are vignettes like this in all of the industries that we want to talk about. So what are some of these better and best promising EMS practices? And I'm taking this out of context. I don't have the same list for trauma centers and emergency departments, mainly because we don't have time for it, and also we have a very large EMS audience today that are very interested and very concerned about health reform. Excuse me. Just looking at call triage screening, looking at what resources we send. Do we send anything? Do we send everything? And on what basis? And one might say, well, gee, that's dangerous to think that way. It is. Honestly, we've had medical priority dispatch systems in this country for years, and we have tons, millions and millions of EMS calls that we now know the outcome of these calls, and we have very high credibility of these screening tools that are available to us. They're just not used to their fullest extent. How about targeting and evaluating data-driven resource allocations, really looking at, starting an IV on each of these patients makes sense, but more importantly is sending the resources that have the capability of driving, IV potentials. You look at Seattle, where they have a very strong, they have one of the best cardiac survival rates, cardiac arrest survival rate, witness cardiac arrest survival rate in the country, and they don't saturate the community with paramedics. They have a very small number of paramedic units, and that is by and large leveraged by a large number of BLS units in that community. And they only use paramedics when paramedic services are data-drivenly needed. What about community paramedicine? An extended paramedic that has skill sets and capabilities to do things like arrive at the scene and determine that their services are really not needed at a traditional level. Their services are more needed now to move that patient to a community clinic, for example, that they might be able to schedule online with their online technology, maybe even link to some of these large enterprise hospital database systems and clinic-based systems to schedule an appointment within the next hour or two, for example, as an alternative to sending that patient to an emergency department. Closest we've come to this at that level of IT integration is in San Diego, where actually emergency departments now, a large percentage of them, can actually schedule a patient for a revisit to a community health center using online scheduling available from the community center. There's a handshake electronically between the emergency department and the community health centers. And the beauty there is the health centers have capacity and they want to see these patients. Many of these are under and uninsured patients and really not properly placed in an episodic emergency department. So why couldn't we move that same capability to the field? So-called mega protocols, where we're looking at, more clinical screening at the scene, at the triage level. And there have been a number of programs, one in Canada that's been around for a long time in Richmond, Virginia, where nurses actually can be the call can be one button transferred to them, and they can actually offer through content-specific protocols that come up on their screens that have been medically tested and medically approved, moving those patients in an alternative delivery system. Or perhaps reality checking, saying, no, you need EMS, you are free to transport these patients. And what about a seamless medical record? Would it not be helpful to have some of that capability as we move to full implementation of EMRs across all of our industries, if they talk to each other, handshook with each other, and more importantly, allowed you to even see that information in the field? For example, a medication list, the last time they had a doctor's appointment, or even to a certain degree the last EKG they saw. Those are all possible today with current technology and capability, all of which could be put into play and have a big impact on the utilization, the appropriate utilization of EMS resources. Next slide, please. All right, well, there's a lot going on in this industry right now. It's received a lot of attention, this so-called community medic, and again, this is thanks to MedStar out of Fort Worth. It's actually got a robust program in place now, more field screening, more community health care, immunizations, and things of this nature. But oftentimes these things were off the backbone of people complaining about, you're kidding me, we're responding to all these resources, and now we don't need to. We look in the EMS industry now, we're looking at frequent flyers more carefully, as they are in San Diego, California, where they're looking at patients that use the EMS system 4, 5, 10, 15, or 20 times a year and saying, yeah, there's got to be a better way. Remember, emergency departments have been complaining about frequent flyers for years. Our studies show that up to a quarter of all emergency department visits go to an emergency department 4 times or greater per year. So as we reach down and drill down to those data sets and try to better understand, is there a better map for these patients and better protocols for these patients so they don't reuse, they don't leave the emergency department to reuse? Can there be similar protocols and capabilities in the pre-hospital care field? And San Diego's initial hypothesis and the data that they're working on in their protocol is that it can happen. Next slide, please. All right, so where do we go from here? Well, I think a big part of where we go is conducting a baseline assessment. You say, well, that's sort of natural coming from a consultant, but this is not an arena where I think you should reach out and just start throwing darts. It's very important that you act, taste, and smell like scientists, okay? I'll just put it out there like that. You really need to know if you're going to look at fundamental reinvention of some of your delivery systems, you better have good data to do it. There's a lot of scared people out there who don't want to do it. And remember, you're not just moving the principles and the policies and procedures, you're moving cultures too. So, there's a whole industry out there that's kind of embedded into doing things traditionally. And we do know that we're going to be impacted. So why wait till that happen? But more importantly, what are we going to do and how are we going to do it? That requires a baseline assessment. Where are the opportunities? and then build on your core strength. So if your core strength is not, for example, in the emergency department, it's not in the area of realigning your triage system and lower cost, but you can do a darn good job case managing patients that come to the emergency department 15 times or greater, and there may be 30,000 ED visit emergency department. There might be 10 of those type of patients. Then by all means, begin to look at a pre-measure and intervention for those type of things using the IHI rapid cycle testing model, or PDSA, and then a result of that. And you can do that in the field as well in terms of looking at precise opportunities for true innovation based on baseline assessments. Next slide, please. So I think this is a whole notion. I'll move through these slides pretty rapidly, of really looking at what we call a SWOT analysis, the strengths of the emergency care system as you deliver today. Next slide. The weaknesses of the system. Next slide. The real opportunities. And remember, this is not a negative talk about, what federal government's going to do to us. This is really about true innovations and being part of that team that helps frame what that innovation looks like for emergency care. And then finally, the next slide, the threats facing the system. Now, one threat that I will tell you right up front, next slide, please, is there are just so many out there. This is just this sort of a quick splash of threats. Innovation to some might look like an opportunity, but to others might look like, wow. For example, in EMS, one of the ways we fund some of our first response system is through the funding of transporting patients. So if we didn't transport patients anymore, where would our funding come from? And how do you do value-based payments? What does that look like? And what if reimbursement goes away? And reimbursement means, and the assumption of the word reimbursement is we're somehow getting our costs back, reimbursing our costs. But if we're based on a faulty framework of why we need reimbursement for existing cost structures that are really no longer valid, then where does that take us? Scary thinking unless we're ahead of the power curve and doing our analysis. Next slide. So just looking at the roadblocks, again, next slide. I think it's really important. The RAND Corporation has been looking at EMS system delivery. This is a letter to MedStar in Fort Worth, but you see here on the paragraph, however, under current payment policy, EMS transports in non-ED settings. That's one of the options: primary care, mental health, treatment on site, inebriate centers, which are being planned in San Jose and in place, for example, in San Francisco, are unlikely to be reimbursed. This acts as a potential deterrent to the development of such programs. Next slide, please. But the RAND Corporation has agreed to continue their search on innovations, and in some respects, some of these innovation grants from Medicare that have gone to some of these local EMS agencies now are really looking hard about the opportunities and maybe the change in payment paradigms are going to be necessary to make this happen. So we really have to be able and willing to put everything on the table as it relates to our thinking process. We may not want to put them all on the table in terms of implementation right away, but our thinking process. Got just a few more slides left, and I'm going to walk through those quickly. I will tell you a little bit about what Santa Clara County is. That's where San Jose is, and when you know it, it's pretty much ground zero for many of us in terms of innovations in IT and technology and what have you. They've developed a process that we're assisting them on, a four-stage process, strategic planning process, where they're willing to take the dangerous look at how EMS is going to be impacted. In this case, it's EMS and some emergency department, and how we're going to move forward in the future on addressing some of these issues and even beginning to think about pilot testing some programs. So again, not waiting for it to happen to us, but perhaps even offering and proactively implementing some of these programs. Next slide, please. The big question will be, well, actually two big questions. First of all, are you going to be at the table? Are you going to be sitting on the end saying, what just happened to me, and look what they're doing to me? That common pity pool thing that we often find ourselves in emergency care, no funding, poor funding, or underfunding, and look what everybody's doing to us. New requirements, less funding. And the other question I would ask in your community, and more of a fundamental question, is there a table to go to? Do you even have a table to go to? And so Santa Clara County, California, has decided there's going to be a table, and they have a very vigorous schedule over the next 3 or 4 months to work through these processes and develop. So stay tuned. There should be a website on that project up and available, and you can certainly come to the Abaris group to see what the results are of that analysis and some of the innovations they will plan ultimately, I believe, to think about. Next slide. So comprehensive planning, in my opinion, is their best tool right now. It's really, there's a lot of fog and, smog and even smoke and bells and whistles out there. So what you need to do is get your arms around this. Look at the metrics and the numbers. You can actually take the number of newly insured. The numbers are available at each county level in this country now. Those numbers, if you have any trouble, you're welcome to reach out to the Abaris group. We'll help you find those numbers. So you know how many more insured they're going to be. And so what are you looking at in terms of your dollars? Next slide. And, it's kind of dangerous out there. I burned myself in the light at the end of the tunnel. Next slide, please. And it's important that, we learn that speed is really of no importance if one is traveling in the wrong direction. So this doesn't have to be fast. We're not likely to see drill downs to emergency EMS, emergency departments and trauma centers, anytime in the next 6 to 8 months. These are really 2 to 3 year strategies. So those are relatively short time frames. But if we don't know where we want to go and what we want to do, then we're going to have something done to us. Next slide. So the other thing is, what about these ACO things that Dr. Regenstein talked about? And should EMS and emergency care, should we be involved in those? And I think the answer is resoundingly yes. We should be part of that mainstream healthcare delivery system and willing to take risk, And ambulance plays a very important role in emergency care in general. That also plays a role in decompressing hospitals as well. Routine interfacility transport is going to have a big impact on whether that hospital has a bed. And believe it or not, sometimes hospitals have trouble finding providers who can get to them timely during the time of discharge of their patients. And guess what happens? That all translates up to the front end of the emergency department where they can't get patients into the hospital emergency department, either on diversion or this new concept called wall time, because they can't get their ED patients admitted. Why? They can't discharge their patients from the hospital. So should EMS, particularly in emergency departments in general, play a role in this area? Absolutely yes. Next slide, please. So are you ready? And another big piece of the health reform has been compliance. So some of that $700 billion is going to be made up with much more aggressive compliance in adherence. So the compliance team at the federal level is going to amp up. And so, for example, if at an EMS, if you're not billing to the quarter-cent level or the every 1/10 of a mile level like you're supposed to on your mileage, just something simple like that, you are fraudulently billing. And on an emergency department basis, if you do not have protocols and procedures in place that are driving your APC charge master, you are likely to be out of compliance just by the nature of the fact that you have a lot of nurses that are applying those charges. In the trauma center environment, all your trauma patients, if you're using a certain billing code called the trauma team activation protocol and you're not doing it through an EMS delivery of a patient, you could be held not compliant. And all of that's going to be amped up in this system. So you need to be ready for that. I'm assuming you're going to be ready for that and that you're compliant in all that piece of it. Let's take the last couple slides here pretty quickly. So this is important, folks. This is hard work. I mean, this is nothing easy about this, but you have time, not a lot of time, but don't sit and wait for this to happen. Next slide, please. I love this one. The woman, she yawned in 62 and her nightmare began. The woman hasn't slept in 30 years. And I love her quote. I just sit in my room and I pray to God for mercy. Is that what you're all doing as emergency care providers? Hoping nothing will happen, sitting back, letting it happen, and pray literally to God for mercy. All right, next slide, please. But there are ways to be innovative, as I said here. There's a lot of different ways to skin this cat, and I think innovation is going to be a key piece and particularly it's the powers in the people who plan and direct this and have the data. That's where the real power is going to be in the future of innovation for emergency care. Final slide. All right, so I just want to conclude that it's been a pleasure talking with you all today about innovation in emergency care and trauma care and EMS, but also about getting ready for this health reform piece. I think it was important. I really congratulate Marcia, for example, of really giving us a primer what healthcare reform is, because there's a lot of misinformation out there, a lot of new insured people, but there's going to be the burden of cost reduction. So we congratulate you all for being on this call, and I see we're up against our time, so we'll answer any additional questions that we've gotten offline. We thank you very much, and thank you for coming to the Abaris Group's EMS, Emergency Department, and Trauma Center webinar on health reform. Good day.